Now I'm going to introduce Chris Shepherdson. He is a physiotherapist with a focus on persistent pain and the complex interplay between the mind and body. Once the clinical lead for our community pain management service, Chris now delivers pain management programs and serves as both a campaign manager and community pain champion for the Flippin Pain Initiative. He is also a member of the MBPA and has been integral in organising today's meeting. Chris is committed to deepening the understanding of Flippin Pain's messages, particularly the principle that everything matters when it comes to pain. This concept forms the foundation of his upcoming presentation, which explores the power of expectation and how clinicians can harness the placebo effect to enhance outcomes both in the clinical encounter and beyond. Chris, over to you.
Thank you so much, Sigrun, for that introduction and yes, the opportunity to speak today as well. A topic that's really close to my heart. Before I break into the presentation, I'm going to try and wow you all with magic trick. Who doesn't love a little bit of magic? And there is relevance to this, so I'm going to ask you all to humor me, if you will. Let's see if I can get a good visual of this. So here I have on my thumb a rolled up packet of hula hoops that were consumed in my kitchen last night by one of the children. So here goes with an attempted magic trick. Okay, so now you see it, now you don't, and then we flick it back on there. So I'm going to do that one more time for you really slowly because I'm sure you're all astonished by what you've just seen. So there's the crisp packet. Now it's gone, and then we flick it back on to our thumb. Now I'm not going to leave you hanging as to how the heck did Chris just do that. I'm just going to do one more time and I'm going to reveal the secrets. I'm going to give you a little bit of additional information and it will hopefully change your perception of this magic trick forever. So now you see it, now you don't, because it's here in my hand, and then we slip it back on. But when done in real time, it looks pretty neat. I hope you agree. So we're going to come back to that magic trick a little bit later on in this presentation. There is relevance to that. So I'm going to move into share my screen now. I've got a little bit of video and sound to play as well. So hopefully I'm sharing this in the right way. And Sigrun, I'm going to ask you to let me know, can you see my slides?
Yes.
And can you see my little red dot floating around here as well?
Yes.
Fantastic. Okay, so we're good to go. And I just want to pass on a thank you to Emily as well for that mindfulness practice. I'm feeling suitably zen and really regulated after that. And it was interesting trying to go through that mindfulness practice, knowing that I was going to be presenting immediately afterwards. And sure enough, my mind did wander a heck of a lot. And it was really nice to have that invitation just to bring it back to the breath. So even though my mind was wandering a lot of the time through that mindfulness practice, I still feel like I was being very mindful because I was aware of my thoughts. I picked up on some of my anxieties here, and I tried to sort of shift and reframe that anxiety to hopefully what is excitement as well, which has the same physiological effect on our bodies. And yeah, hopefully just bringing myself back up to a healthy level of adrenaline as I deliver this topic. Welcome all to an overview of placebo, nocebo, and the words that hurt. Thank you, Sigrun, for that kind introduction. So a little bit about me. Please call me Shep. That's what all my friends call me, and we're all friends here. I am a physiotherapist. I do wear a few different hats as a clinical specialist pain practitioner, predominantly delivering online pain management programs. I also hold a role, or a couple of roles, for the Flippin Pain campaign, which again, I'd be hopeful that a good proportion of you are already aware of. I represent them as a community pain champion and also a campaign manager as well, organising some of the events that we put on across the country. And yes, I am part of the NBPA for my sins as well. And I'm really representing a combination of all these roles as I speak to you today. But in reality, it's the 6 key messages of the Flippin Pain campaign and in my endeavour to better understand them, which has led me to present on today's topic, or more specifically, this one, that everything matters when it comes to pain. But let's set the scene with a really brief overview of what I think we're all pretty comfortable with when it comes to pain. And when we say everything matters when it comes to pain, we mean exactly that. Everything that feeds into our nervous system, both from the external world, but from our internal as well, can influence that experience that our brain creates for us. And then if we consider the nervous system more broadly or in a more focused way, what is the main purpose of our nervous system? Well, when it comes to doing well in the animal kingdom, us humans are a pretty successful species. We've become top dog. Yes, there might be other animals who are stronger, faster, bigger than us, animals that can fly or swim better than us. But despite all of that, we've become the most successful species that's ever existed. So we're top dog. And if we are top dog, just out of interest, I wonder if anybody here knows who the top dog of the top dogs is. It's Chuck Norris, of course. They made a movie about it. But how did we become top dog? What is it about us that's given us the capacity to get there? Well, ultimately, it's about how good we've become at surviving. We wrote the handbook on this, and we've evolved to become experts in keeping ourselves safe from harm or danger. Or in short, we're really great at finding ways to stay alive. We're the best there is at staying alive. End of debate, really. We're so good at staying alive, we even wrote a song about it to celebrate it and have the odd disco dance to it when the conditions are right. So we humans have developed a nervous system that is great at keeping a healthy distance or a barrier between us and threats to our safety. Our nervous system is, of course, our protector. The control center for this system that protects us is our brain. And in the middle of that control center is a relay station called the thalamus. And this processes all the information from our body senses and the external world. And it sends this out to the brain's cerebral cortex for interpretation. And this in turn prompts a chamber of debate throughout all the different parts of our brain, which ultimately leads to decisions being made about this information and how best for this human of mine to respond to it. And I like to think the response to this decision is made by this little fella, this character in our brain. Let's call him Hector. Hector being our decision maker. Put simply, Hector takes in all sorts of inputs every second of every day, processes all of this complex information and produces an output, or more accurately, a best guess prediction of what this information means to us and therefore the experience that we will go on to have. And the output that Hector produces for us could be things such as what we see, what we hear, what our body does, what we feel, all of that, what we experience. And this is, of course, Hector's best guess, his interpretation, his prediction, given the information that he has to hand. Now, most of the time, Hector gets this pretty bang on, but there are times where certain combinations of inputs can result in Hector not getting things quite right. Hopefully, like my magic trick, for example, the information that you initially had to hand made it seem like the crisp packet had somehow miraculously been thrown from my left armpit to land perfectly on the thumb of my opposite hand. But when I did the big reveal, you give Hector some additional information and he then gains an entirely different perspective on things. And for the purpose of this talk about placebo, nocebo, and language, our main focus is going to be on how our feelings, our thoughts, our expectations, our memories, and our beliefs can influence our present moment experiences. And there's plenty of examples which can demonstrate how Hector making his best guess for us based on his prediction doesn't always get it right. Prediction is the reason why we all see these two squares on the Rubik's Cube as different colors. We see the top one as brown and we see the bottom one as orange, even though they are in fact exactly the same shade of brown. However, Hector and his prediction machine doesn't just decide what we see based on that singular input of the light energy hitting our retinas, but also takes into account our previous experiences, our beliefs, our expectations, and ultimately comes to the conclusion that even though the light energy from these two squares is exactly the same, this lower square happens to reside in an area of shade, and therefore it must be a brighter color, and therefore Hector makes this adjustment for us. But even though we now know this new additional insight, this information, it's not enough to override our unconscious experience. We still see it as orange and we still see it as brown. However, Armed with this additional information, we are in a position to better rationalize things. Even though I'm experiencing this, I know it's not necessarily the case. How we're primed by other people can also influence the experience that our prediction machine creates for us. So coming up next, you've already had a quick glimpse of it. I'm going to show you a picture of a duck looking to the left. Or is it a rabbit? So again, we can flip-flop between the two. If we're thinking duck, we will see a duck. If we're thinking rabbit, we will see a rabbit. And we can change depending on those thoughts that we are feeding into our prediction machine. Speaking of rabbits, on the next slide is a video of a cute little bunny having his nose tickled. Just watch this, this rabbit's nose being tickled. I'm hoping it's going to play. Is it going to play?
Not a, oh, maybe.
Ah, there we go. There we go. Look at that cute little bunny, really quite satisfied. But it is, of course, not a bunny rabbit. It's a bird. It's a raven, in fact, having its head scratched. But hopefully, the first thing that you saw was based on that priming that I gave for you to see the rabbit having his nose scratched rather than the other way around. But yeah, look how happy that raven is sat there. The next thing I'm going to do is show you an image and maybe throw in the chat some of your answers. This is the bit where you start getting interactive. And Sigrid, I can't see the chat, so if you can maybe throw at me some of
Yeah,
the
no problem.
that people make of this. Yeah, what do people see in this image? Give you a few answers to put your suggestions in. What imagery are we getting? Can we see anything at all? What are we making out? You got anything, Sigrid?
No, no comments yet. Feel free to, in the Q&A, what do you see? Just type what you see and I'll feed it back to Chris.
Perhaps
I
we're
have,
finding
I
hard.
have no idea what I can see there.
Okay. Interrupt me if anything comes through, but because what I'm about to do
We've got
is
random
provide
shapes.
random shapes. Random shapes is yeah, yeah, it's about right. There's no real sort of pattern to this, is there? But what I'm about to do is provide your brain or your prediction machine, your Hector, with some new information for just a split second. And after I've done that, that will fundamentally shift your experience of this picture, not just for the next day or two, but for the rest of your lives. You will never see this picture the same way again. Okay. Any other suggestions before I do this? Apart
Maybe a
from
face.
maybe a face. Okay, yeah, I can see that. Maybe just in the middle here. I understand that one. Okay, you ready for the new information? 3, 2, 1. Okay. And now we go back to it. Now, I'd like to think with that new additional information, everybody now sees what this picture represents. And you kind of can't unsee it. You're looking at it now and you think, yeah, God, of course, it's a bulldog wearing a human's baseball cap. So armed with new intelligible information, our brain can produce a fundamental shift in our experiences, not just short term, but long term for the rest of our lives. So in summary of the prediction machine, when it comes to vision, we do not see things as they are. Rather, we see them as we are. And pain works in this way too. It can be heavily influenced by both existing, but also by new pieces of information that might feed into our prediction machine. And when it comes to pain, this is where Hector becomes our protector. Which moves us on nicely to our main topic around placebo and nocebo. So what are they in the first place? Well, placebo is a positive physical and or psychological change driven by positive expectation that we have regarding a treatment. For example, after taking a medication that doesn't contain an active ingredient like a sugar pill, or a sham treatment like simulated surgery, or any other experience that we're subject to that contributes to having the effect of hypoalgesia or pain relief. And nocebo is the exact opposite, nocebo being the influence of negative expectations on a treatment effect. For example, if you know someone who's tolerated a particular medication poorly, it's more likely to be less effective and or cause side effects for you, simply from this negative association that you already have with it. So nocebo effects, in summary, really result in hyperalgesia or an increase in pain. And few scientific ideas have generated as much excitement or as much outrage as the placebo effect and the potential of the mind-body connection. A really early reference to contextual factors, so not explicitly therapeutic, but how context can be important to treatment success, was from ancient Chinese medicine. The Yellow Emperor's Inner Classic, which was first published over 2,200 years ago, stated, if a patient does not consent to therapy, in this case acupuncture, with positive engagement, the physician should not proceed as the therapy will not succeed. So this statement suggests an appreciation that contextual factors were a highly relevant factor in the success or lack of a treatment. Fast forward to the birth of modern medicine in the 18th century, doctors were acutely aware that certain sham treatments could bring relief simply through the patient's beliefs about them. But could they ever really heal the underlying problem? And even if they did work, didn't their inherent dishonesty break the doctor's ethical code? These were enormous questions that troubled none other than the third US president, Thomas Jefferson, in all his glory here in the slide. In 1807, Thomas expressed his fear that some doctors were becoming overzealous with their administration of common medications of the time, such as mercury and opium, which he feared were often doing more harm than good. He believed that many complaints could be better served with the illusion of medical treatment. Once writing, one of the most successful physicians I have ever known has assured me that he used more bread pills, drops of colored water, and powders of hickory ashes than all of the medications and medicines put together. So this deception may have seemed morally dubious, but it was preferable to the over-prescribing of potentially toxic substances that brought about no further improvement for the patient. It was, as Jefferson put it, a pious fraud, or an ethically grounded fraud that ultimately was serving the patient's best interests. Awareness and debate increased in Western literature through the 19th and 20th century. In Henry Beecher's milestone 1955 paper, The Powerful Placebo, the placebo groups of post-operative patients were examined. And it was found that 35% of those experiencing severe post-operative pain were satisfactorily relieved by a placebo intervention. But such findings, however, were paired with skepticism about the benefits of belief. For some practitioners, placebos were better seen as a diagnostic tool to identify potential malingerers or hypochondriacs. If you found relief from a sham treatment, you didn't have a real disease. So by the mid-20th century, articles in medical journals would label placebo responders as unintelligent, neurotic, ignorant, and inadequate. The Lancet described the placebo effect as a humbling humbug. Why would anyone spend time researching such an inane phenomenon? So as a result of this continued skepticism, and high-level skepticism, by the way, as well, the science of placebo has taken a really long time to truly blossom. But we now know that positive expectations can produce real, genuine relief from many physical conditions, including asthma, Parkinson's, heart disease, and of course, chronic pain. Even more astoundingly, the cure often occurs through the exact same mechanisms as the actual drugs prescribed to treat these ailments. The mind-body connection is real, and it's potentially really, really powerful. And the underpinning mechanisms for the placebo effect have been proposed as a synthesis of both conditioning and expectancy. So conditioning operates on a subconscious level, where repeated pairing of a treatment like an injection, or for example, something like a smell with an experience of pain relief, can lead to the treatment or the smell itself triggering the exact same relief, even without the active drug. Think Pavlov and his salivating dogs when it comes to conditioning. On the other hand, expectancy is all about our conscious beliefs. If somebody expects a treatment to work, that expectation alone can drive a positive outcome. And this theory really aligns pretty smartly with current models of chronic pain, particularly the biopsychosocial framework and this modern understanding of how the brain processes pain, both through top-down and bottom-up mechanisms. But what proof do we have of placebo and nocebo effect taking place in the wild? And well, let's start with the now infamous tale of two nails. I think everybody's pretty familiar with the first, maybe less so with the second example. But the first nail story, in 1995, a British construction worker jumped down from a ledge, looked down to see a 6-inch nail, as shown in the picture, sticking through his boot. He had immediate severe pain, was rushed to the local emergency department. And upon arrival, any small movement of the nail gave him such severe pain that they sedated him with fentanyl and midazolam. Upon carefully removing his boot, it was found that the nail was in fact between his two toes, and there was no tissue injury at all to his foot. So this guy had severe pain with absolutely zero tissue injury. His pain was real, but his pain was driven by the nocebic factors of fear and context rather than actual tissue injury. The second nail tale, in 2007, a case study was released in the journal Laryngoscope describing a construction worker who had unknowingly shot a 4-inch framing nail into his head, as shown in the image. Now, the context of this was he saw the nail responsible fly across the room to the other side. But the reason the mechanism jammed was there was actually 2 nails in the chamber. One flew out across the room, no guesses for where the other one ended up. But he just felt like the discomfort that he had was as a result of the nail gun kicking back and jabbing him in the face like a blunt trauma rather than anything else. He went on to have a low-grade mild toothache, and it was only 6 days later that he didn't go to see his doctor. He went to see his dentist, and his dentist took an x-ray, and only then the nail was found. So this guy had minimal pain, but severe tissue injury and indeed threat to his life. But his mild pain and attributing it to a simple toothache was driven by placebo-inducing factors of the context and a blissfully ignorant lack of awareness of harm or danger or threat. So how is it that Hector got this so wrong on both cases? Well, consider the complexities of how each example might have led Hector to come to these vastly different conclusions. In the nail in the boot, the inputs to Hector would have included vision, seeing the nail through the foot in a dangerous place like a building site, feelings of fear and uncertainty. Previous experiences would have been brought into play there. Standing on something sharp in the past has always been distressing. When I've stood on glass or stood on stones or stood on a Lego, this is like that, but it's much, much worse. Thoughts, what if I lose my foot? If I can't work, I don't get paid. I could lose everything. I'm scared. I need help fast. This is really dangerous. The meaning, I need that foot to walk, to work, to play. I could lose it. Hector's decision, pain and protection and all the actions associated with it, lots of it. Pain, 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 until his updated information and inputs allow for a very vastly different prediction. When he sees there is in fact no nail through his foot, he feels safe, he feels fine, there's no need to protect, and therefore no pain produced. A bit like the update that you had with the bulldog and his cap. Once you are armed with this additional information, your worldview of that moment in time completely changed, and the same happened for this chap. Conversely, in the second example, the inputs would be, I saw the nail go into the wall or fly across the room. I'm also in a dangerous place like a building site where accidents can happen, but the feelings would be different. Feelings of frustration and annoyance. I feel a bit stupid, a bit embarrassed. Previous experiences, this is a blunt trauma. I can expect, a little bit of discomfort for a day or two, but all above board. It'll bruise, but it'll be fine. At least it's not bleeding. All these tasks, this work I've got to do still needs to be completed. That's more important to me right now, so I better get back to it. I better keep this to myself. in case my colleagues take the mick out of me for making such a burk of myself. The meaning, yeah, I can expect a dull ache from a blunt strike. Nothing to see here, move on. Hector's decision doesn't need too much protection. The danger is past. I'll maybe be a bit more cautious moving forward using that nail gun, maybe sort of hold it a bit further at arm's length. Take actions to make sure this doesn't happen again. I'm going to learn from this. And yeah, I've got a small amount of pain for my troubles. So there were two case studies out in the wild, but placebo and nocebo has also been demonstrated in countless numbers of clinical trials in all manner of health conditions across the globe. But here are a few highlights from the pain world. So this first study was in 2001, a study of patients who'd undergone a thoracotomy, and they were receiving post-operative analgesia, a combination of buprenorphine analgesia, and they were hooked up to a saline infusion as well. Now, the first group was told that this infusion was inert. It had no analgesic properties at all to it. The second group were told this infusion may or may not contain a powerful painkiller to complement the buprenorphine. And the third group was told that this infusion did indeed contain a powerful painkiller. They were reassured or assured that it did contain that, when for all three, it was in fact just saline. Now, all groups with that combination of buprenorphine and saline recorded exactly the same degree of relief, same degree of pain relief. However, the third group that was told the saline infusion was an analgesic drug used 33% less buprenorphine. The second group used 20% less. So the expectation of analgesia, reinforced by the verbal cues that were given, influenced their requirement for the actual analgesic. They needed less of it to get the same level of pain relief. Busy slide, this one, but a study by Howe et al. In 2020 explored how the characteristics of a clinician might influence a patient's response to placebo treatments. In this case, it was a placebo cream after they were subjected to a histamine test and an allergic response that would naturally ensue an inflammatory response. So their findings suggest that factors such as a clinician's warmth, their competence, and their confidence can significantly impact the patient's experience of symptom relief. So in this case, such factors resulted in a reduction in physiological allergic response, but also reduced the recovery time from that allergic response following this histamine test, significantly so. Two groups of 70 healthy women at full-term pregnancy prior to having a local anesthetic before an epidural were given two priming statements. One group were told, we are going to give you a local anesthetic that will numb the area and you will be comfortable during the procedure. Whereas the other group were primed with, you're going to feel a big bee sting. This is the worst part of the procedure. In the reassuring language group, the median pain VAS score was 3. But in the fear-inducing language group, their VAS score at that point of the procedure was 5. So again, a highly significant difference. But it's this piece of research that I find absolutely mind-blowing. What we believe as clinicians unconsciously influences the outcomes of our patients. Take a look at this randomized controlled trial where they were trying different pain medication injections for pain relief during tooth extraction. So this is from the world of dentistry. This was a paper from the 1980s. Now, all the patients were blind to what they received in the injection. The clinicians, however, were partially blind. They knew people were either in the red group using the red injection or the blue group using the blue injection. Now, they also knew that if you were in the red group, you were either going to receive placebo or naloxone, neither of which would bring about any pain relief. And they knew that people in the blue group were receiving either placebo, naloxone, or fentanyl. So only the fentanyl should produce some pain relief. So the people in the blue group had a 1 in 3 chance of getting pain relief. Now, the clinicians did not know exactly what was being injected, but they did know those two options. Now, if we look at the data, what we see is, as expected, those in the red group, their pain levels increased in the hour after treatment, as one would expect if you're not expecting relief from the injection. Now, in contrast, those in the blue group, as expected, we see some relief in the 1 hour after injection, as one might expect if there was a 1 in 3 chance of improvement. But here's the key piece of information. In that data set, every single participant received a placebo injection. The only difference was the clinician's belief in the potential success of the intervention. In the red case, the clinicians believed there was no chance of relief. And sure enough, nobody got any relief. In the blue group, the clinicians believed that there was a 1 in 3, there was some chance of relief. And sure enough, people felt relief, despite there being no difference in what people actually received. So what this data tells us is we as clinicians heavily influence the outcomes of our patients unconsciously. Exactly how? Who knows? But if you just think about that for a minute, if you believe that pain cannot change, then you are immediately harpooning the effect of whatever intervention you go on to deliver. If you believe that people can't recover, then you're immediately harpooning the chance of them recovering. Your beliefs are every bit as important as the beliefs of your patients. And this isn't just a case of a shift in subjective feelings, but a biological shift that occurs in our body. Anything that suggests placebo can activate our body's opioid system and the production of pain-modulating substances such as endocannabinoids and oxytocin. Anything that suggests nocebo generates the opposite effect within our biology, including the production of cholecystokinin, CK, which can amplify, increase our pain experiences. So when we talk about placebo, it's not simply a case of mind over matter. Rather, it is our mind that creates our matter. And these modifications are triggered by different positive or negative contextual factors, which can include patient's expectation, clinician's behavior, as we've already discovered, beliefs on both sides of the treatment table, therapeutic touch, a positive therapeutic encounter, a patient-centered approach, social learning, open and well-explained administration of the interventions, the dosage of the intervention, the physical size of the pill. The bigger the pill can often lead to a greater effect or a greater degree of side effects. The modality of the treatment administration, the marketing that goes on regards to a treatment. We heard from Claire earlier talking about how much patient-facing advertising there were of painkillers in the US, for example. But also verbal suggestions, the latter of which I'm going to focus on for the remainder of my talk. But in summary of the placebo effect, to take a quote from earlier and steal it and kind of make it my own, we do not feel things as they are. We feel them as we are. Which moves us on to consider the role of language in the conversations and the communications that we have about pain. We all know the old saying, sticks and stones may break my bones, but words will never harm me. Well, I beg to differ based on the science, because words are, of course, the most powerful drug used by humankind. The words we choose can contain either the capacity to heal or have the potential to cause lasting and devastating harm. And so your words are powerful. Words are like drugs. They've got the ability to change the way somebody thinks and feels. They can generate good or bad emotions or prompt actions that can lead to both positive or negative behavior changes, everything that we're looking to work on in our circle of employment. And let's start with the language of imaging. Now, I think it's safe to assume that the majority of us will be aware that the MRI scans of the asymptomatic population typically show a plethora of structural changes in the absence of pain. So here's a chart of the findings on MRI scans of the asymptomatic populations, people in their 20s, 30s, 40s, right through to their 80s. And because of the prevalence of these findings, we can therefore interpret such findings and their near universal prevalence as not pathologies, but normal age-related changes, the kisses of time, wrinkles on the skin or grey hairs on the head, as we refer to them. And yet we as a health profession have pathologized these findings and commonly lay the blame for somebody's pain squarely at their door. But a patient who comes in to see us who's already in pain, they're already worried and they're naturally predisposed to hook onto and fixate on the negative rather than the positive. And the conversations that we have, the words that we have, the things that we see, the words that we hear or read are like toothpaste. Once they're out there, they're impossible to put them back in. Once you saw the bulldog in the cap, you could not unsee it when we flicked back to the original image. So next, what I'm going to do is just sort of a real life story of Pete Moore of Pain Toolkit fame, and he's talking about how his MRI scan was explained to him in the early days of his relationship with persistent pain, and the actions that he went on to take as a result of this.
I did actually get to have an MRI scan, and it showed up that I'd degeneration of the discs in my lower back. It's the two lower vertebrae and one in the centre. What they've shown is more or less like bone was sort of rubbing on bone, really. So, okay, but the words they use, okay, I guess at the time frightened me. They use this word degeneration. I was thinking, God, well, if I've got something degenerative, and I better just be really careful what I do. So again, I had this thinking, well, if I've got something degenerated, I better not be too active in case I wear things out even more. And they also told me that when they showed me this, they said, oh, your spine is like a digestive biscuit. Again, you know, I thought, well, if I move at all, I may make things worse. But by not moving, as I found out later on, I was making things a little bit worse, because I was becoming more and more deconditioned.
A digestive biscuit. Poor old Pete must have been avoiding cups of tea for fear they might dissolve his spine. They didn't even use a hobnob, something with a bit of steel in it. So I think instead of comparing humans or their bodies to pieces of machinery or kit, would we not be better off using metaphors related to our bodies being a bit more like an ecosystem, like a garden, for example, something that can evolve, adapt, and grow and potentially flourish, depending on the love and nature that we apply to it, depending on the environment and the conditions that we create for it. So when you scan the back of somebody with persistent pain, you statistically increase their risk of a poorer outcome. So the information that we hear and read can influence Hector. Negative, inaccurate information can fan the flames of pain, whereas positive, accurate information can help extinguish it. And if that weren't enough, a lot of the language and metaphors for pain easily unite with warmongering metaphors like stabbing pain, the horror of pain, I'm tortured by pain, or the treatment's been a painkiller. I'm fighting the pain. This idea that pain is always as a result of tissue damage or this attack of pain. And all of this will naturally facilitate this ongoing state of fight or flight in response to the perceived danger. So what can we do? Well, ask ourselves questions like, what does this all possibly mean to them? And how can I help them find a positive outlook on their situation? Asking questions like, what is the meaning of your pain to you? Establish a baseline understanding of that patient perspective, or step into their world with a plan to meet them where they're at, rather than expecting them to meet you where you're at. Imagine a patient with fibromyalgia, fatigued by years of failed treatments, and you prescribe a gentle graded activity plan and say words to the effect of, many patients start to feel a little bit better within 2 weeks of this. Let's see how your body responds. That's expectation setting. That is placebo engagement, and it's without deceit, and it works. Frame your outcomes positively. Many people with similar symptoms have found this helpful. Avoid overemphasis of the risks. Most people tolerate this really well. Some report mild symptoms like a brief headache. So you're not focusing on the side effect, but just acknowledging it, but without emphasis. Validate and normalize their experiences. It makes sense you feel this way. It's your body's way of trying to protect you. Project a calm confidence. This is a step forward. There's learning from this. We'll keep adjusting until we find what works for you. And use this collaborative language. We'll work through this together. We'll walk these miles together hand in hand, or I'll guide you and provide guidance and direction. And introduce new treatments with optimism. There's good evidence this approach can help people living with pain. Let's see how it works for you. But also take full advantage of the powerful and influential voices of lived experience and their recovery stories. The Flippin Pain website, for example, has over 25 broad and varied real stories of individuals whose lives have been changed immeasurably following a reconceptualization of their pain. And recovery stories show that others like me, like you, have improved, even after living with symptoms for many years. If they did it, maybe I can too. Hearing that somebody recovered without a fix challenges their beliefs, can calm the nervous system. Stories often describe the actionable steps that were taken by that individual, like pacing and movement and a mindset shift, making patients
Chris,
feel more in control. Yes?
can I hurry you up? We're over
Yes,
time.
two more minutes. So hearing someone say, I learned pain didn't mean I was broken, can reshape our internal narratives. And these compelling stories, because they're human-to-human connection, they activate mirror neurons and emotional resonance. And this social connection with my fellow human going through the same taps into the same brain systems involved in healing, trust, and pain relief, amplifying the placebo effect. So in short, recovery stories act like emotional and cognitive medicine, delivering belief, connection, and hope, all of the factors that can reduce pain through these brain-driven pathways. And I am wrapping up now, just to finish, really just getting down to the nitty-gritty of even how single words that are commonplace throughout pain conversations can influence the outcomes. Common in the notes and the letters that we write to our patients, these letters that patients read over and over again. And as each word registers, our brain makes associations with the meaning of that word to us. Take, for example, suffering. Think and picture the word suffering and the imagery and the associations we make with it. And suffering frames pain as an all-consuming negative identity that makes people out to be a passive victim. So instead of the patient suffers with arthritis or suffers with fibromyalgia, how about a swap to say this patient experiences fibromyalgia? Now, to say this patient experiences isn't inaccurate, nor is it invalidating. It still captures the suffering that may come as part of this, but it doesn't focus exclusively on it. Pain is a part of life, but not their entire life. And this empowers individuals to see themselves as active participants in their condition. Vicious cycle, one bit of the brain says it, another bit of the brain hears it and believes it. One of my first memories or experiences of vicious was when I watched The Never-Ending Story as an 8-year-old boy, and it had this vicious beast, Gamork, who stalked the main protagonist. So when I hear vicious, a little bit of my brain goes back to that terrified 8-year-old boy. So again, is this going to foster a sense of soothe or safety or danger or threat? Let's call it an unhelpful cycle. And this just acknowledges the same pattern, but without adding that layer of fear or judgment, encourages curiosity in how we can interrupt those cycles and alter them. And finally, struggles, which essentially implies a fight. I don't know about you, but I've never felt comfortable, safe, or soothed while I've been in the middle of a fight. So instead of this patient struggles with, how about this patient has challenges with? And in doing so, frame them as a challenger, trying hard, showing courage and defiance in the face of adversity, learning new life skills to help them cope, and focusing on the things they can do rather than being stuck in this continual fight. And I'm wrapping up now with just a summary. What can you do now? Help people feel heard and understood. Mind your Flippin language, both in the conversations and the notes in the letters you write. Can you avoid iatrogenic harm? Take full advantage of these rich and inspiring recovery stories. We're going to hear from Antonia after the break, talking about the power of storytelling. And know that your beliefs make a hell of a difference. And the final point, never ever compare any part of the human anatomy to a baked good. Thank you for listening.
So thank you so much, Chris. Shep, sorry. We are a little bit over time, so we've got about 5 minutes for questions. If anybody's got anything, please use the Q&A function. I know the chat function is just for the panelists, so if you've got any questions, please use the Q&A. It has been pointed out to me that I think people who are attending are unaware how many people are actually on the meeting today. So we've got about 60 people in total who are sitting all hiding in the background. So don't be shy in chipping in and asking any questions. I suppose I had one question, which was what I think, it's all well and good when we're, watching our language. And I remember sort of learning all about this and then getting so hung up on my language that I got to the point I could almost barely speak to patients. And now it's become a bit more second nature. But I guess when they're coming to you and they're already describing a lot of that stuff, they're telling you, you ask, what does this mean to you? And well, it means that, like you say, I'm crumbling. How can we challenge that?
Yeah, and I guess it goes back to those initial questions that we suggested, meeting that patient where they're at, and what does this mean to you, and who have you spoke to about this before, and what have you been told? And at that point, I guess they may come up with a response that you do disagree with, and is quite inaccurate, and rather, I guess, than impose your view on them and say, well, you're dead wrong with that. Spines don't crumble, or these things don't happen. So it's really interesting to get that perspective on it. Would you like to learn a bit about persistent pain, back pain in this case? Can I maybe invite you to consider some resources to go away and have a little bit of a self-directed learn from? Take this information in and then come back in our clinic and we have a bit of a conversation about it. Now, it may be that it maybe changes some of those perspectives that you have, or you may completely disagree with that. But that's a conversation that we can then have. But a bit like, words are like toothpaste. If they've sat through that information, if it's been delivered in a compassionate way, an understanding way, then they're going to be looking to listen to that they're in pain management because they're dissatisfied and they're looking for an intelligible alternative. And that's what we are there to deliver. And I guess our skill, our knack, and you talk about how you've evolved with that and become acutely aware of your language and stumbled and fumbled over it to begin with, but then it becomes second nature. And I think the fact it's already become your second nature already increases your influence over that person. They may use that word, you hear it, and you sort of reframe it back to them as, instead of a struggle, a challenge, instead of suffering, as an experience. You can capture them and say, I'm not a great fan of the word vicious. And you can sort of get them to sit down and say, picture vicious. What springs to your mind? I can show them what springs to my mind and say, what do you think this is feeding into to your hector, to your nervous system? Is it going to evoke a sense of soothe or calm or control or danger and threat? Hopefully when you start maybe bringing in some of these dialogues, they've already had that introduction to pain science and the biopsychosocial perspective. And long-winded answer to your short question, Sigrun, but does that help?
Yeah. And Kieran Dinwoody has said, great, thanks for the talk. It would be great to have a table with the phrases to promote and phrases to avoid. Do you know of any resources that have something like that? He works as a GP, so only have short periods to land the message, and those phrases would be very helpful.
Yes. There was an editorial by Mike Stewart, maybe 7-8 years ago, called Sticks and Stones. And within there is a table I had included in this presentation, but it was already overrunning and I've actually removed it. But there's a nice sort of side-by-side turns of phrases, but more than happy to sort of add a few of my own to that. Those three that I picked were just a sample few. But we all know about this, don't we? And we're looking for that shift from I can't and I don't know how to, I want to, but I'm not sure where to go with this, to I could, I would, I will, to I do. And that's not just an overnight success story. It's this path to recovery that takes several months, if not several years, for them to get to. But we noticed our patients' language starts to shift as they get more invested in this and as they start to embody the rewards and outcomes from that. Fab. Extra point there from Kieran.
Yeah, no, there was, we're sort of running out of time, but he's also commented we're working on something similar for the Scottish Government Effective Prescribing Guide, which will be coming out later in the year. Fancy collaborating. So I'll leave that one for you to think about in the background, because we're now going to move on to our poster blitz. So I can hand over to you, Lynn,